Hello, David.
Hello. So I'm introducing Professor Owen Bowden-Jones, who's a medical doctor, is a psychiatrist and a researcher with more than 20 years experience of helping people with mental health and substance use. He works through the NHS and in private practice. Previously, the chair of the addictions faculty of the Royal College of Psychiatrists. He's the author of The Drug Conversation, which is advice for parents about how to talk to your children about drug use, which is brilliant. And I'm really looking forward actually to the one you do for schools, teaching teachers how to talk to young people about drugs. I actually know as a drugs worker that if those conversations were happening when people were young, we'd be having a lot less problems. He's also the chair of the Advisory Council on the Misuse of Drugs, which, amongst other things, helps the government to have better cultural understanding of new drug trends and the communities who need more support, advising the government on how to channel funds and recommend training to support these communities. He's the lead of Project Neptune, which is very comprehensive clinical guidance for healthcare workers on emerging drug trends, including crystal methamphetamine, which we'll be talking about mostly today, a very long chapter about that. He's the founder, I think for today's purposes, he's the founder of the consultant psychiatrist of the Club Drug Clinic. He has a kind curiosity about new drug trends, about the people and their vulnerabilities and their mental health and behavior. He possesses a true earnestness to help, and that definitely includes colleagues. And I've been very fortunate to have worked with him, with you, over the last 10 years. Owen, welcome.
Thank you very much. That's a very generous introduction. I think the only person who's got a longer biography than that must be you, David. So thank you for that. It's really kind.
I do have to edit some things out too, but these are the ones that are particularly interesting for the people who probably be watching this, especially in the fact that I would think it's probably fair to say that there isn't another psychiatrist in the world who has worked with as many chemsex patients as you, or certainly as kindly as you. I'm pretty sure that's the case because if you work at Club Drug Clinic, you do work with a lot of chemsex patients there.
Yeah, so the clinic started about a decade ago, just over a decade ago. And I think it'd be fair to say that the sort of majority of people who come and ask for help are coming and asking for help with chemsex or chemsex related issues. So it has been thousands of people over the last decade.
And I guess they've been very lucky because chemsex is a relatively kind of new phenomenon, and a lot of people in the world are struggling to find the right support in their cities. But I guess right in the early days, we've had the benefit of having psychiatric support in chemsex contexts. Can you tell me what is a psychiatrist's job in working with a chemsex patient?
Yeah, absolutely. So, I mean, maybe I'll start with what is a psychiatrist? Because, I mean, I think sometimes that's a sort of confusing word to people. So the terms people tend to get or tend to hear a psychiatrist, psychologist, and psychotherapist, and they can all seem to be one of the same. So, I mean, a psychiatrist is a medical doctor, so someone who's been through the normal training to become a doctor and then specialized in mental health. And one of the things that psychiatrists can do is they can diagnose different mental health conditions, and they can also treat them. Both through talking therapy and through prescribing medications. And then a psychologist is someone who focuses just on talking therapies, and a psychotherapist is another type of person who focuses on talking therapies. So I suppose people often go, well, what is the difference? And they sort of go, oh, well, doctors can prescribe medication. But it's a little bit more than that. It's more about the integration of the physical and the mental health problems and the abilities to diagnose and sort of think about a plan that is more than just about the drug use.
I think a lot of those misconceptions happen a lot from a lot of American TV movies. I find there's a lot of blurring of lines of what those roles are. And yeah, as a drugs worker, lots of people get very confused about, I only want to see that person because I know what that person does. And could you then describe to me the multidisciplinary, an ideal multidisciplinary team and a kind of pathway that a person who's having trouble with chemsex might go through?
Yeah, so this whole concept of a multidisciplinary team is a really interesting one. And what it really is there for is to make sure that the care that someone is given is individualized to them. So every person who comes through the door of the Club Drug Clinic will come with a different set of issues, different set of challenges. And so there's no one team that would be right for everybody. And so what we find is, as we get to understand someone's problems, someone's challenges, we then go, okay, so what sort of help, what sort of expertise do we need to bring together to be able to support that person? And it's never just one person who has all the expertise. So that's why you need a sort of range of people who've got different sort of specialties. So for example, as a psychiatrist, I come with the ability to diagnose mental health problems and treat things like depression or anxiety, as well as addiction problems, but also think about people's physical health problems. So sometimes we'll do physical examinations or think about doing treatment of physical health problems. But then we have a load of other people who work on our team. So it may be that that particular person who's coming through the door needs help around trauma. So for that, we have psychologists. We have nurses who might be able to, for example, vaccinate someone for hepatitis or direct someone towards HIV care. We have a family therapist and a couples therapist. So if there are issues around social networks and around relationships, then that's something that we can offer support with. Then we have people who are experts by experience, who will have a very different set of expertise in which they can support that person. We also have, for example, a psychosexual therapist. So if the issues are very specifically around sexual intimacy, then there's someone on the team who's sort of expert on that. And the sort of way I think about it is, you know, imagine the MDT as a sort of box of paints and with lots of different colors. And if your challenge, as we often see, is coming in and making sense of what's going in your life, almost painting a picture of what's going on in your life, you need lots of different colors to be able to sort of imagine that image. And in a way, the MDT gives the person coming through the door asking for help a whole range of different options, colors to choose from, to be able to sort of paint that picture of their life and what the challenges are and what the solutions are.
It's an ideal situation as someone that helps people, other health services in other countries around the world where they just can't get that together. It's quite a luxury. I think you talked about trauma too. There is, if someone, what is the kind of trauma that might lead someone to use drugs, or is the trauma you see more often the trauma that happens afterwards in people, the experience of people that have had on drugs?
Well, I mean, every person's individual, and so people's stories are unique. And so we see a sort of very wide sort of range of those stories. Some people will come and will have experienced quite a lot of trauma in their life, and their drug use is essentially a coping strategy, a way of self-medicating to take away some of that hurt. Some people have experienced trauma directly from their drug using experiences, and unpleasant or difficult things will have happened to them in the context of using, which will have sometimes made it easier to continue using just to try and forget about that. So trauma is a very common experience of people who come to the Club Drug Clinic, which is why we do spend quite a lot of time thinking about trauma and thinking about how we help that. Because we often find that unless you sort of get to grips with the trauma and help people process that, then it can be a driver to continued sort of quite sort of chaotic and harmful behaviors and experiences for people. And so you can spend a lot of time talking about substances, about drugs or this and that, but unless you get to some of the root causes, you can often go around in circles.
So I'm often with a person or talking to somebody who might be very aware of the trauma that they've got, and it's very obvious that some of the reasons that they might be doing drugs is because of this, but they might be using a couple of times a week. And so it's, for me, I might have just got to make an assessment of, you do need to see a therapist to get some of that trauma addressed. but they're not in a state to be engaging in therapy because of too much drug use. And sometimes a psychiatrist can help in that moment if a person is struggling to, because of mental health and trauma, they're struggling to learn craving management techniques and struggling to get their drug use under control. So sometimes I can refer them to a psychiatrist to do what?
Well, okay, so again, it's very individual, and I suppose our starting point with something like that is to say, well, what's your goal at the moment? What are you looking to change? And we hear a whole sort of variety of different things. So some people will come and talk about, well, I'd like to stop using drugs, or some people say, I don't want to stop using drugs, but I want to use a little bit more safely, or I want to use in a bit more of a controlled way. Some people come and say, I'd like more friends. I'd like friends. I'd like to feel that, people around me cared for me. Some people come and say, I'm struggling at work and, I'm worried I'm going to lose my job and I need some sort of support to make sure that doesn't happen. And so people's goals are the starting point for anything that we do. And we very much work towards the goal that people bring. So even if we think, and it does happen sometimes, even if you think that someone's goal is going to be quite hard to get to, quite hard to reach, or that they picked a goal that we think, I don't know, is that really the best goal? We still work with that goal, absolutely commit to trying to get that person to the goal that they want. Now, of course, people's goals do change. So we quite often find that once people are in treatment, they begin to get a bit more a sense of what's going on, what the challenges are, and then they might say, do you know what, I actually want something different now. Now I've been in treatment for a few weeks, I feel a bit more settled, I'm not frightened about what treatment is, and it's a very sort of challenging thing to come into treatment. So sometimes people just need a bit of time to get used to the service, feel that get a sense of who we are and how we can help. And then people's goal changes to something different, and that's also absolutely fine. In terms of the role of psychiatrists, though, what we sometimes find is people set a goal. So say that goal might be, right, I've had enough of using drugs, I want to stop using all the drugs, I want to stop the chems, and I want to try and live my life without chems and see what that's like. And that they really, really struggle to do that. So despite all the support that we offer and all the effort they put in, it just for some reason doesn't happen. They keep relapsing. Now, that would be a good reason for us to go back and have a think with them again and just say, is there anything we're missing here? Is there anything that we haven't thought about that we should be considering? And so quite often we'll find that actually that person is suffering with a depression, or that person is suffering with an anxiety disorder, or there'll be some other issue that's going on that maybe wasn't that clear to start with, or that was masked by the drug use. And so it was very hard to see. And so that's where, we might then have conversations about people's mental health, and whether there's some treatment we can offer for that might then have a knock-on effect of making it easier for them to achieve their goal.
I loved what you just said, because a lot of gay men are very familiar with learning how to hide things. We're hiding our sexuality, we're acting straight, we're performing and acting right through our childhood to the people who love us the most. And so we get really, really good at acting. And so we also become really good at hiding our mental health and depression as well. That's you finding a way to bring that up and checking again, that's beautiful. You were talking also about goals and things. When a person is trying to achieve goals, but they keep on failing, or their goalposts keep changing and they don't know why. And this week they're regretting that they did change their goalpost on Saturday because what they wanted on Tuesday was what they really wanted. But the cravings are so strong that they never achieve their goal. Can you help a person to understand what's happening in the brain when you do things when you don't actually want to do them?
Yeah, that's a really good question, because it's very confusing for people, isn't it? And I think what you said there is really important, that people want different things at different times. So what people want on a Tuesday morning, it can be quite different to what they want on a Friday night. And, you know, that's where we start working with people about triggers, and start thinking, well, you know, what is it that makes you feel different on a Tuesday morning or a Friday night? What's the environmental situation that might be influencing that? You know, what's your emotional state, or what might have happened? And so we quite often use things like drug consumption diaries or mood diaries, or some way for people to begin to check in with themselves in terms of what they're feeling at the time. And what we often find is that there will be a very clear trigger for people feeling different at different times. And so a trigger might be an argument with someone you care for. A trigger might be someone sending you a text. A trigger might be someone offering you chems. You know, a trigger might be your depression worsening, or having a panic attack. Depression might be hearing from a relative who judges you very negatively. There could be lots and lots of things that change the way that you feel, and in fact what you desire in that moment. And of course, what we tend to find is that when people are experiencing particularly intense emotions, be they negative or sometimes even positive, that the way to cope with those is often to reach for the chems, to reach for something that just takes those feelings away temporarily. And so, you know, identifying what's caused those feelings is the first step. And then you can begin to think, well, how might you do it differently next time you feel like that? And that's, you know, at the core of the work we do, is help people to sort of almost, you know, take their own emotional temperature and begin to recognize when that temperature's got too hot or too cold, and then what to do about it.
Because when the temperature's too hot, they can't access all of their problem solving mechanisms, process things.
Exactly. So you know, when the emotions get too intense, what happens is that the all of the well-developed strategies and good intentions, they just become harder to access because the emotions tend to sort of overwhelm them.
So I guess we all experience that. That's like with chocolate too. I might be want to be on a chocolate diet on Wednesday. I mean, you know, not eating chocolate on Wednesday, but in a moment at the supermarket when it's right in front of me and there's a busy queue, I lose it and I buy the chocolate. But then on Wednesday next week, I'm complaining about it. I'm wanting someone to fix that. And fixing it is, I guess, managing cravings and recognizing triggers like that in advance. Things like, is that what you mean?
Absolutely. So if you're in the queue in the shop and there's chocolate, as they always do, they put chocolate just at the checkout, so you know where you're standing, and there's chocolate surrounding you, you know, and there's a big queue, so you're a bit stressed about the queue as well. You can see how you can develop an environment where it becomes much easier to buy that chocolate. And it's the same with substances, it's the same with physical intimacy, it's the same with a whole range of things. And so then it becomes about thinking about that in advance. And a lot of what we do here is helping people to plan a bit ahead. So, you know, if you're going to a party where you know there's chems, well, the chance of using chems is much, much greater. Now, what we also don't want to suggest is everyone needs to live as a monk, you know, shut away in their house, never seeing anybody, because of course that's unrealistic as well. So it's about firstly identifying what are the situations that might be triggering, or what are the emotions that might be triggering. And sometimes these are feelings. So for example, hunger can be a triggering emotion. You know, sometimes people, if they haven't eaten, will get triggered to use or to go on the apps. And so it can be something as simple as making sure you eat regularly. And that can really just help regulate and make your emotions, you know, feel a bit more stable. And then once you've identified the higher risk situations, it's, well, you can either avoid them, or you need some really good tools to start using straight away when you're in that situation, and find ways to sort of manage that. I mean, we do also sometimes, in addition to the psychological approaches, we do sometimes prescribe medicines. So we at the Club Drug Clinic prescribe something called naltrexone, which can really help some people who are struggling with stimulant use. It just makes it a bit less desirable to use. The cravings just ease a bit for some people with the medicines. So sometimes we use a combination of the psychological and the medication. And then probably the most important bit, though, is self-care. And the reason it's probably the most important bit is self-care really is about self-esteem. And it's really about caring for yourself and valuing yourself. And so we talk a lot with people about good nutrition, about regular exercise, about healthy social networks. These are really, really important things that if people can get those right, it makes everything else so much easier. Because actually, by the time they're doing those, they're valuing themselves and they're saying, well, I value myself enough to look after myself, to eat well, to, think about, what I need to flourish. And when people start to get into that headspace of thinking about what do I need to nurture myself, that's a really, really good place, because then you can start to have some really useful discussions about, about chems, about physical intimacy, about other behaviors, and actually all flows from self-esteem.
You're describing a whole lot of things, like there's not a single magic pill or a single kind of therapy or a single magic wand that can fix a person who's got like an addiction problem. It's very much about improving life, achieving goals, sometimes some medicine, self-care. It's quite a lifestyle change sometimes.
And that's why it comes down to, you mentioned the multidisciplinary team, because, if you think of all of the things you just mentioned, there's no person who's an expert in all of that. And that's why we need a range of people at the Club Drug Clinic who are all able to add a little bit on all those different things to try and help that one person. And we generally do that using something called a care plan, which is a document that we sit down with someone and we go, right, this is your goal. Let's try and think how we're going to get there. What elements do we need to think about to see how we can get you from where you are now along this journey to the destination that you've identified? And that care plan will have lots and lots of different elements on it, and different members of the team will be involved in different aspects.
In regard to the chems themselves, and I guess we're pretty much talking about crystal methamphetamine, methadone, and GHB. Why, you don't have to know the answer to this, but why is it such a sexual focus on those drugs, particularly, why are they so good for sex? Do you know why?
Well, we don't really know why, actually. We know that stimulants are disinhibiting. They give you a massive rush of a neurotransmitter, a brain transmitter called dopamine. So it gives you a massive euphoric experience. But it's really not clear why some people end up feeling very, very sexually disinhibited on stimulants. Because interesting, methamphetamine is used in the UK by mainly gay men in the context, or men have sex with men in the context of chemsex. But if you look around the globe, actually methamphetamine is used in all sorts of different ways, and it's not always associated with sexual behaviors. So I imagine people will have seen Breaking Bad and things like that, where the same drug is used in a very different way. I mean, GHB is a bit different because GHB is a muscle relaxant, so that facilitates anal sex. And I think, that also has a sort of disinhibiting euphoric effect, and methadone as well. But of the three, it does seem to be the methamphetamine that people say take them to that often unexpectedly dark, sexually disinhibited place, which is a story we hear regularly here at the Club Drug Clinic.
Yeah, that pretty much defines chemsex too. I mean, I think there are, as you know, a lot of people who just use it for fun, but you do need a really robust toolkit to do harm reduction with those drugs. Because if you've got nothing to disinhibit, if you're at ease with your homosexuality, if you're at ease with your gayness, if you're at ease being naked and intimate with other people, regardless of some complications that might have happened when you were younger, or concepts of intimacy or gayness, if there's nothing to medicate and you're just enjoying it, you still need some help from a good drugs worker to manage those drugs safely, harm reduction information.
Absolutely. And of course, you've led the way with that, really, David, in terms of, thinking about how to be safe. I mean, that's, at the end of the day, that's what a lot of people do come and ask for. They say, I want to be safe. I don't want, I want the good side without all the downside. And some people are able to do that, and some people are not. And in a way, one of the challenges is working out which group you fall into. If you fall into the group where you can have fun and you just, you take appropriate care of yourself, then, there doesn't seem to be an issue there. But you need to make sure you're not in the other group. And you just haven't quite realized.
But I think the message that you and I are always sending out is use drug support services, not just for when things go wrong. Please come to the doctor, because they're usually, in nearly all cases, they're full of people who are really kind and really want to help keep you safe and give that harm reduction information. A question I get asked a lot also is when people are experiencing problems with chemsex is it the drug I've got a problem with it, or is it the sex I've got a problem with it? How do I separate them? How would you, when regard to chemsex, how would you describe whether it's a drug problem or a sex problem, if it's a problem?
So that's a really interesting question, and it's a really complicated question. And it comes back, I think, to what we were talking about earlier, which is everybody's story is unique. And so we see some people who will very clearly tell us, this is about drugs. I go to the parties to get the drugs, and the sex is irrelevant, really. And some people even go as far as saying, what I really experience is a needle fixation. What I really want to do is inject. And that's the thing that I get excited about. That's what brings the whole value of the experience to me. Then we have other people who go, the drugs I could sort of take or leave. It's the physical intimacy, or even the emotional intimacy. It's the socialization that is the important thing. This just connects me to people in a way I find very difficult. And so it just helps me feel part of something and part of a community. And then most people don't know. So most people fall in the third group go, this is all really quite complicated, and I don't know what's going on here. And I need some help to try and figure it out.
Psychiatrically speaking, is sex something that is using the same parts of the brain as a drug high might, the sexual arousal?
Yes, so it all runs through dopamine. So that's our feel-good chemical. And so physical intimacy absolutely does release lots of dopamine. I mean, nothing releases dopamine like a stimulant like methamphetamine. I mean, that's just the way to use all your dopamine up straight away. And so that's why the high and the euphoric experience of stimulants is just so powerful and difficult in a way, because there's nothing in day-to-day life that can replicate that. And so when people come in and say, it's the high that I'm after, what we can't do is say, oh, well, if you go for a walk in the park on a sunny day with your friend, you're going to experience the same euphoria, because you're not. And it's almost about accepting, that euphoria is very, very intense, but it comes with so many consequences that actually it's not worth it in the long run. And that there will be other behaviors that will, give you pleasure, will give you good feeling, but won't have all of the negative effects. But, it is challenging.
If you're struggling with a habitual dopamine release, like with methamphetamine, and that's part of what you're seeking help with, but if it's every time you do it, you're also doing it with the sexual dopamine release, and your question might be, well, how do I have sober sex again? It seems like every time I try to have sober sex without the chems, I don't feel even capable of going near sex.
And that's, that is probably the most common experience that people have coming and coming to the clinic, that just the concept of, sober physical intimacy it feels unachievable, particularly when people have been on the chem scene for a long time. And in a way, it initially it will be unachievable, because if you've used regularly chems, then actually it probably takes up to a year for your dopamine system to sort itself out and return to its normal state. And so people tend to, if they've stopped using something like methamphetamine, will often go 3, 6, 12 months of not experiencing pleasure in the same way. And, that's a long time to ask people to wait to start to feel good about things again. But unfortunately, it can be that long for some people. And so we tend to start quite early in preparing people for that experience of, you step away from the chems, you step away from the whole chemsex scene, and you go, right, okay, I've done really well, I've stopped using this, surely now I can just get on and enjoy physical intimacy without chems and it'll all be fine. And of course it isn't, because it takes a while for the brain to recover from that dopamine almost deterioration that's happened. Sorry, my computer is just popping up loads of messages. Let me just stop this.
I'll have another question, which is...
There we go. All right. Sorry about that.
No, it's okay. Do you want to pause?
No, I'm just... my computer's decided to join the conversation. It's sending me about 50 different messages all at once. There we go. It's all gone. It's all good. You can rerun that one if you want.
No, carrying on from that, you're talking about the brain recovering from dopamine. So a lot of people also come to the drug use support service saying, I know there's something wrong with my mental health. I know I can feel it. I've sensed it all my life. So I want someone to diagnose me with what's wrong, because surely that'll fix my drug problem. And they're using quite regularly, like this week. So I know that a mental health assessment or a diagnosis is kind of complicated, and you've got a process of how that time-wise what might happen. Can you tell me about that?
Yes, so absolutely. So one of the difficulties in understanding people's mental health while they're still using drugs, even if they're using only perhaps every weekend or every other weekend, is that many of the effects of the drug use mimic the effects of the sort of mental health problems we might be looking for. So a really good example is ADHD. And so we see a lot of people here who struggle with ADHD. We see a lot of people who suffer with depression or anxiety. And the problem is that the drug use can mimic all of those effects. And so the approach we take at the clinic is we say, we can't really make any proper diagnosis until you've been at least a month without substances. And at about a month, so about 4 to 6 weeks, we get to a point where we can sit down with someone and do a really good assessment of their mental health and have a better idea of what's going on in terms of what might be helpful, what the diagnosis might be. While they're still using it, it becomes really difficult to do that. Because, for example, we see people who go, my God, my anxiety is terrible. I've got an anxiety disorder. I'm getting panic attacks every day. Please give me some antidepressants or give me some anti-anxiety medication. And actually, once they've stopped using, for example, crystal, the anxiety's completely gone away. And so what we don't want to do is start treating conditions that actually may be entirely related to the substances, which may just stop and disappear once people make a change around that.
Because it's hard to put this delicately, but sometimes when people are, what part of the nature of a complicated relationship with drug using is sort of sometimes blaming everything else except the drug for what we're feeling. It's a way that we as human beings function in denial. We want the drug so earnestly and our brain wants it so earnestly. We find other reasons in life to explain what's upsetting us.
Yeah, and I also think that, you know, people, particularly people who self-medicate, you know, they've got in the habit of going, if I take something, it will make me feel different and it'll make me feel a bit better, even if it's just temporarily. And so what can happen is that they come and see someone like me and go, give me an antidepressant, because that will be something I can take that will make me feel better. And sometimes that's absolutely true, but sometimes that's just part of this process that external things are going to fix you, when actually the real challenge is doing the internal bit about self-esteem, self-care, you know, understanding the trauma. You know, that's the bit that really needs working on, rather than just something else from outside that's going to influence it.
We are living in an age of instant gratification. It's hard to read an article without a link triggering you to look at something else. And everything's so fast and quick and immediate gratification. And drugs are very much about that too. They fix something now, and it's hard to think of the long-term consequences of what that's doing. And you mentioned crystal meth, sometimes taking a year of recovery before you're fully back to a kind of robust self. And some people just can't think that far ahead, and a year can seem miserable.
Yeah. And that's why I think when you start trying to help someone, we usually work in segments of no more than a couple of weeks. You know, we go, right, okay, this is the goal, but that goal's, you know, some way off. And what we're going to do is break this journey down into little sort of smaller journeys. And all we're going to do is think about the next couple of weeks and what the smaller goal might be for those few weeks. And I mean, you'd be very familiar with, you know, the 12-step movement, talking about one day at a time. And, you know, there is a reason for that, that actually for many people, a day is a huge sort of chunk of time to make change over. And, you know, can be incredibly challenging just to change things for one day, let alone for 1 year. And so I think focusing down on these really achievable, smaller chunks and goals is a very helpful way just to make people feel manageable and not overwhelmed.
Yeah, I think it can seem really overwhelming and impossible and unanswerable, and like there's something incredibly wrong with me. And so breaking it down into just achieving one small goal, like I didn't use today, can give you such a sense of accomplishment and realize you're not as messed up as you thought you were. And it really help. It's crucial, I think, in our job. I want to ask about crystal meth psychosis now, because it is one of the main things that brings people to services. And I saw a stat the other day that 5% of England A&E presentations are meth psychosis, which is incredibly disproportionate, considering that really it's only MSM using crystal meth mostly in England, and that's quite a large proportion. I know it from the communication I get online and the calls for help online, and my own work as well. Crystal meth psychosis is very prevalent and very scary. What is happening? What's going on? Why is it so much like schizophrenia?
Yeah, so this is another really sort of fascinating question that we don't really have the full answer to. I mean, essentially, there are three things at work here. The first is the drug. So, you know, how strong that drug is, how long you take it for, the route that you take it, so whether it's smoked or injected, will all have an impact on the risk of someone developing psychosis. The next is the environment within which the drug is taken. So, you know, some people use at home, some people use in the midst of a chemsex party. You know, there will be some environments that are more likely to make people feel psychotic. But probably the most important factor is the genetics of the individual who's using that drug. Mm-hmm. Because we see people with almost identical histories of using crystal. And yet one person will never experience psychosis, and the other will go psychotic every time they use crystal. And so it probably in that case is not really so much about the drug, all so much about the environment, but it's about the genetic vulnerability of the person using the drug. And often what we find is when we look through people's family tree, and we spend a lot of time asking people about the emotional health of their relatives, we often do find that there's a history of psychosis somewhere in the family that's probably given that person genetic vulnerability. And I think the sort of simple message is this: if you've gone psychotic using crystal, then you need to think really carefully about your crystal use, because once you've gone psychotic once, the risk of you going psychotic again is much, much greater. And it does seem that the more times people experience psychosis, the greater their risk of further psychosis. So it's like a bonfire that you chuck on extra wood. The more you go psychotic, the bigger and more out of control this bonfire gets. The other thing that's really perplexing about crystal meth psychosis is some people are psychotic for 6 hours, 12 hours, 24 hours, but within a week will be feeling pretty much back to normal. And other people have a psychosis that goes on for months and months and months. And we don't really understand why some people experience that so differently. It will be perhaps to do with how much of the drug they've taken. It may be perhaps to do with the environment they took it in. But again, I suspect it comes down to genetics. And so some people are just vulnerable to psychosis. And as I said, they often do have some sort of family history somewhere. It might be a great aunt, or it might be a great grandmother, or it might be quite far away in the family tree. But you usually do find there's some sort of mental health issue somewhere.
You mentioned environment too. I myself have been in COVID, spending a lot of time by myself in the house, and even that can affect your sense of what's going on in the world. You can find yourself talking to yourself, or having arguments with people that you probably wouldn't argue with if they were there in real life. And I think sometimes you mentioned environment when you're really high and in a very intense environment where there's lots of perceived judgment everywhere, that can get out of control too. I've heard you say before, you've been particularly concerned about when young people are experiencing it, even if it's just the first time, like a 20-year-old. Is there particular harm for young people who are experiencing it?
Well, I mean, the challenge is that between mid-teens and mid-20s, the brain is still developing really, really quickly. And so we talked a bit earlier about dopamine, and all of those sort of dopamine systems and a whole load of other neurotransmitter systems are still getting established and built. So it's not until your sort of mid-20s that your brain has sort of got those structures fully in place and matured. And the danger is that if you experience psychosis, or if you use a lot of substances during that building period, sometimes the building goes wonky, and actually the structures are not really set down and laid down as they should be. Mm-hmm. And that can have consequences later in life. And so what we do see is people who have experience of drug-induced psychosis in that vulnerable period of mid-teens to mid-20s are much more likely to have other mental health problems later on in their life. So if I had a magic wand, no one would use anything before they were 25. Right. And actually that would probably, have a pretty significant impact on people's mental health.
Yeah, well, good luck with that one.
Yeah, exactly.
But I know that even if you are using them, and your book goes into this quite well, but if people have so much about drug use is about stigma, ignorance, naivety, shame. And if these conversations are happening in school and in our families as young people, then we are going to be better informed, more accessing more help more easily, identifying when this doesn't feel right and going to talk to someone about it much more easily. I do wish these things were talked about in school, although I'm not really sure if everyone needs to learn about chemsex psychosis in school. Another question I have about chemsex psychosis was, Um, what do you, when you're with someone who's experiencing psychosis yourself, what do you do for that person? How can you manage that person?
Yeah, this is a really important question, because this is, we talked a bit about trauma earlier, and actually we do see people who have experienced a trauma through not knowing what to do when someone they really care about gets very unwell with drugs, whether it's an overdose or whether it's psychosis. And it can be incredibly difficult for people trying to manage a situation that they're not trained to manage. Someone's, overdosed, or someone's, really in need of urgent medical care. And psychosis is a very good example of that, where, there'll be someone there who's clearly very paranoid or clearly very agitated. And I suppose the first thing to do is take them out of a setting that's very stimulating. So if it's a chemsex party, it's about saying, right, okay, let's get you somewhere that's calmer, it's not so stimulating. Let's see if we can get you home, perhaps get you to get some sleep. Just try and de-escalate the situation. And sometimes that will be enough. And by the next day, people will wake up and actually they'll feel much better. So that's probably the first step. I mean, I think if the situation's a bit more difficult than that, and someone's very, very agitated or very hostile, or worried that they're being, for example, chased, or that someone's going to harm them, then probably the best approach is to try and take them into the A&E department. Now, I say that in a funny way. Of course, A&E departments are quite stimulating places themselves. And so, another option might be to call an ambulance. And actually, the ambulance crews are incredibly good at helping people in acute mental distress, and can often administer medicines at the scene and help people feel a bit calmer and able to then go and get a proper checkout in hospital. So I think the right thing to do depends a bit on the situation, but de-escalating first, I'd suggest. But if someone is really, really unwell, then they're going to need professional help, and it's either calling an ambulance or taking them to A&E.
I agree. In my experience too, you can't really make it go away. You can make someone feel safer, and it might de-escalate the situation, but it's so easy to get woven into a conspiracy theory or something, even when you're doing your best. But just the mood of the situation is the best thing you can do, I think. When we're talking about GHB or GBL, this is one drug amongst the chems that you're most likely to need emergency support or psychiatric support with. Can you tell us about that?
Well, I mean, I'm an addiction psychiatrist, and I've been working with lots and lots of different drugs over the years, but GHB, GBL is a really unique drug in terms of how quickly people get dependent on it, and how quickly they experience withdrawals if they try and reduce or stop it. And so, it's very common for us to see people who will be using their G almost hourly, who will need to carry their G around with them so that they don't go into withdrawals. And it's actually a really very dangerous withdrawal. So, people get ill very, very quickly. The risks include sort of seizure, delirium. It's just a nasty withdrawal syndrome. It's also, of course, a very easy drug to overdose on, as many of your educational tools talk about. A small difference in dose can be the difference between having a good night and being in a coma. And so it's a really hard drug to sort of manage. And we see even experienced GBL users get it wrong sometimes and go under on G or go into withdrawals on G. So it's one of those drugs that needs really careful medical input if people are dependent on it. It's something that we don't recommend people try and detox themselves at home. Of course, people do, but it's a much more dangerous thing to do. than if they actually went to a clinic like ours and got support to do it more safely.
Yeah, I guess the main reason I liaise with psychiatrists is because people have accidentally become dependent on G, and it's even frightening for doctors to figure out too, I think, and you do need someone that's pretty experienced with it.
Yeah, it's just one of those drugs that creeps up on people. You know, they think it's fine, and they think they're useless, and then 2 weeks later, they seem to have just very quickly slipped into a dependent relationship with the substance, and it's unique among drugs in terms of how quickly that happens.
When I was young, I used to keep Valiums around. Usually they're meant to be for after my clubbing experiences, or for that occasional moment when I got really anxious. But yeah, just by accident, I would have 3 nights in a row when I took one, and then the 4th night I wouldn't sleep, and I'd need one, and it would just turn into a dependency that way. And G's kind of can be exactly the same, the way it creeps up on you that way, except that you can die really, really quickly, which wouldn't happen with Valiums, I think.
Yeah, absolutely. So it's a very difficult drug.
I think I've got like a final question, because I don't want to keep you too long, and I've kept you a long time already. Thank you. I think, and I've got 2 questions. One is, what's the most common mental health thing that you see that is driving Chemsex when it's problematic?
Well, I mean, I think, David, you probably taught me this back in the early days of the Club Drug Clinic. You taught me a model called internalized homophobia. Mm-hmm. And you explained to me this whole process about this sort of interface between traumatic early experiences and shame, internalized shame, and how that very potent cocktail leads to people inadvertently being self-destructive later in their life. And I think that is what we see most often, is this experience of people who have often had a pretty tough time growing up. Some pretty unpleasant things have happened to them. And they have also been handed this sort of package of shame that's got their name on it. And that combination in adulthood just leaves them really vulnerable to things going wrong. And I think that's our most common, and in a way our most complex sort of situation that we try and support people with.
Which kind of does bring me nice to the last question, which is kind of you work with a whole lot of gay men engaging in chemsex who come with a whole lot of problems, and they're sharing such personal, intimate things with you that they might not share with their best friends or their mums or with anyone, that they sometimes, because of that shame you just mentioned, can't share with anyone. Do you have an assessment or a compassion or something that kind of sums up this community and what they're going through in relation to chemsex and sex and drugs and community?
Yeah, I mean, I think what we've developed over the years at the Club Drug Clinic is a sort of culture. We try to develop a culture in the clinic that is understanding, empathic, but also very professional. So what we try and do is, when we come in, we very much treat people like sort of, come and tell us how we can help. We don't have any sort of magic sort of tools or things that are going to be, that we can just hand straight to you. It's going to be a journey. And in a way, we see ourselves as sort of co-pilots on that journey. We can't do any of the driving, but we can sit next to people and give them some sort of suggestions about the direction. And that's the culture that we've developed here. So it's a lot of people's experience of dealing with doctors and health services is it's quite paternal. They go in and they expect it all to be sort of fixed, that the doctors, the nurses will all have the answer and be able to sort it all out. And we're very clear with people right at the beginning that that's not how it works here. we want to hear their story, we want to share their journey, we want to offer what advice we've got. But at the end of the day, they're in the driving seat and the choices will be theirs. But we are there to support them every step of the way.
That co-pilot thing is kind of really gorgeous. Yeah, and it does sum it up too, that there is no magic fix for this, and co-piloting someone kindly and with your term, cultural compassion, with cultural integrity and competency. That was my final question. You answered it beautifully. I just want to thank you. You've seen so many of our Chemsex patients. You've seen so many people from my community. You know I care about them a great deal, and they've been really lucky to have you as a co-pilot as part of their frightening journey. They're really lucky to have you, and I thank you as well. Thank you.
David, it's a pleasure to talk to you as ever. I look forward to seeing you very soon.